Hi guys, I hope that you are enjoying your neuroactivity day. Hopefully it will teach you everything that you need to know for your exam and also for working as a nurse with the possibility of having a patient who has spina bifida. First, we're going to start off talking about, the whole thing is talking about myelodysplasia, also known as spina bifida, or a meningomyelocele or myelomeningocele. Back in my day, it was known as myelomeningocele, so that is probably what I will say. Now, if you have to have spina bifida, the occult variety is the kind to have. With spina bifida occulta, there may actually be no sensory or motor defects. The baby may be born with just a small dimple or a tuft of hair on their sacrum, or they may even have a small lipoma. Again, this may not present as a big deal. The child with spina bifida occulta may not have any neurological or motor deficits. Now, when it gets to be a problem is spina bifida cystica. That's a completely different story. With this type of spina bifida, there is a sac-like protrusion that is filled with the meninges and the spinal cord and spinal fluid. There's usually no skin covering up this defect, and it looks a little bit like their guts have spilled out. It's a really serious complication. The higher up on the back it is, the worse the effects will be. Think of this as a type of paralysis, because in essence, it has many of the same effects of a spinal cord injury, because this is a spinal cord injury. So just like with a regular spinal cord injury, the higher it is, they will be affected from that point down. So obviously the lower on the spine the meningocele is, the better. Now, the infant born with spina bifida has to be handled very, very carefully until surgery can be completed. Usually surgery is done within the first 24 hours after birth. There are even some doctors who are going in and doing the surgery while the baby's in utero. But as you guys may or may not know, this can really present some complications, because you always have the possibility of the baby dying, or being the mom going into labor, infection, all those different things. So the baby could end up being born too early. So most doctors wait until the baby is born. We're very lucky in that we have ultrasounds now that show what's going on. So typically parents will know before the baby is born that this is going to happen. As soon as this baby is born, it is going to be whisked away from the parents and taken to the NICU, where the first thing the nurses are going to do is protect this myelomeningocele. They're going to cover it with sterile 4x4s that are soaked in normal saline, and this keeps that sac from drying out and protects it. You also want to watch these babies. They may be leaking CSF from the wound, and do you remember how to check for that? You actually would go get a keto stick and check for glucose in the fluid. Now, whenever you do this 4x4 soaked in normal saline, this is a sterile procedure, and it's going to need to be repeated as often as necessary to prevent drying of that sac. Now, most children who are born with the myelodysplasia will be affected with at least bowel and bladder function, so eventually they're going to be put on a toileting schedule. The infant with this is going to constantly dribble urine and poop. So until they can get the baby taken care of, they're going to put a little dam between the myelomeningocele and the baby's bottom to keep that clean and dry. You're going to put that baby on their knees, or on their tummy with their knees bent, and we're going to make sure that they can actually urinate. Some of these babies can't. They'll either dribble urine or they won't be able to empty their bladder at all. And if they can't empty their bladder at all, we're going to have to either put in a catheter or in and out cath them. For the newborn, they're just going to put in a catheter. You want to really monitor these children for infection. If we do in and out cath them, those are going to be done several times a day to empty that bladder. And typically once they get home and are in a normal environment, sterile technique is not used. It's just a clean in and out catheter. Now post-op, you're going to monitor for wound healing just like you normally would. These babies are at really high risk for it because we have broken through that blood-brain barrier. You know, if there's infection in that CSF, it's going to take it straight to that brain. So we have to really watch these babies for signs of meningitis. We also want to monitor for hydrocephalus and increased intracranial pressure. About 80% of the children born with spina bifida have to have a shunt to prevent hydrocephalus. Again, once post-op, we're going to put them in that side-lying position. Measure that head circumference because we are checking to make sure they are shunting the fluid away from that brain properly. Make sure they don't have that hydrocephaly. Obviously, once that starts going up, we'll have to put in a shunt. As these kids get older, it's very important that these kids be given the opportunity to complete a task before help is given. As far as long-term care goes, parents have a tendency to be overprotective of their children, of course, in any situation. And then these children really have a tendency to be overprotective. The parents have a tendency to do everything for them, and instead of helping them, sometimes that hinders the children from being all they can be. It's very important that these kids be given the opportunity to complete a task before help is given. It's really important that parents give only the help that's needed rather than helping with the entire task. There's a very fine line between too much and not enough help. But in order to increase these kids' confidence, we're going to try to let them do as much for themselves as they can. Now, in the long term, we're also going to avoid latex because these kids have so many procedures done so often that it is very common for them to get latex allergies. We also want to do meticulous skin care. Not only does the infant dribble urine and stool, but once they're older, they may not have control of those functions. So if we're not in and out catheting them, they're going to be in a diaper. But they're also going to be in leg braces all the time. So meticulous skin care is very important to prevent breakdown. These kids also end up having multiple surgeries because what's going to happen is over time, they're going to have more and more orthopedic problems associated with the spina bifida. So they're going to have PT and OT for a very, 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 very long time. And we want to make sure that these kids get the opportunity to have the best life experience possible. Most of these guys can grow up and be pretty independent. There is some deficit in neurological functioning occasionally, so we have to be very careful with that and not release them before they're ready to fly. Hope that's helpful. There are some websites here that have some very good information on them. Go look at those if you have extra time and enjoy.